This episode of Precision Opinions Live is brought to you by Vintage Labs. Vintage Labs is a professional-grade supplement and cosmetic company where each product is tested and reviewed by one of their exclusive pharmacists. Look for the pharmacist's signature on every package that ensures that the active ingredient falls within 5% of error and does not contain arsenic, lead, cadmium, or mercury. We welcome you to join the Vintage Labs collection, where they do the research for your health. Use promotional code LIVE, that's LIVE, to receive a 10% discount on all orders at vintagelabscollection.com.
Precision Opinions Live, and I am Christian Stella, compounding pharmacist at Precision Compounding Pharmacy. And today I'm here with Dr. Glen Z. Brooks. Thank you so much for coming on. I appreciate it.
Chris, my pleasure. Happy to be here.
All right. So going through Dr. Brooks's bio very briefly, it's very extensive. So I'm going to make it as short as I can. He's an anesthesiologist. He completed his training at Harvard, Brigham and Women's Hospital. He taught at Yale University, which is fantastic. 2011, he started a detox for opioid addicts. In 2012, which he is very, very well known for, he founded his New York Ketamine Infusion Center. So that's in New York City, where he treats patients from different countries, different areas of the United States. He also treats about 2,400 different patients on ketamine infusion strictly. And he has patients as far as the Philippines. So Dr. Brooks, thank you for coming on. And I think we could guess what today's topic is. What do you think? Ketamine? Is that a good topic or what?
Ketamine's where it's at.
All right, good. So we're going to start with the basics. We'll get into the basics very quickly, and then we'll go from there. So first, we're going to start with what ketamine is, how it works, kind of the mechanism behind ketamine, and what it's used to. What do you treat with ketamine?
Yeah, ketamine's a very interesting medication, Chris. It's not at all new. Ketamine's been with us since the Vietnam War. What it is and has been, first and foremost, is an extremely important human general anesthetic agent. Not a horse tranquilizer, which is urban folklore.
That's a big rumor out there, correct?
I don't even know where this stuff comes from. I really don't. But it's been a very important human general anesthetic agent now for over 5 decades. As an anesthesiologist, I've been working with ketamine now for 48 years. In hospitals, we use it in operating rooms, emergency rooms, intensive care units, burn units, pain centers, radiation therapy, pediatric anesthesia. All my kids have had ketamine for wisdom teeth extractions. It's on the World Health Organization's list of top 10 essential drugs.
Wow. So, and then you hear that commonly. When I say ketamine, I say we fill ketamine prescriptions. People come back and they say, oh, it's a cat or a horse tranquilizer right away. It's the first thing that comes out of their mouth. So how young are these patients, would you say, for the most part? Do they, how young?
We see adolescent teens and folks into their 70s. The average age is 35, but it is a full spectrum. Success rates do vary with age, though, so age is important. And so we're pretty honest with patients and telling them what the chances of them responding to ketamine are. The biggest predictor of who responds to ketamine is really the story, okay, their psychiatric history. But second is age, and success rates do vary. When we get young adults, folks in their 20s and early 30s, success rates can be as high as 75 to 80%. Again, we're talking about otherwise treatment-resistant patients. Ketamine isn't the first stop. Ketamine is generally one of the last stops.
Correct.
Most patients have been in therapy for a number of years. They've been on a variety of different psychiatric medications, sometimes 15 to 20. Many have been hospitalized. Many have had shock therapy. transcranial magnetic stimulation. I mean, the list goes on and on. So by the time they get to us, they're generally considered treatment resistant. In other words, nothing else has really helped. So when we talk about success rates, even a success rate of 75% is pretty remarkable. Now, when folks get into their 70s, that can drop down to 50%. Even that can be a dramatic improvement over their current status.
Yeah. So you're dealing with patients who have depression, anxiety, OCD, post-traumatic.
Our patient population for the most part is post-traumatic stress from childhood trauma.
Okay.
And when you talk about childhood trauma, that doesn't need to be physical or sexual abuse. That is true for a third of our patients, maybe. But for the other 2/3, the emotional and psychological traumas can be just as devastating. And it really runs the full gamut of all the things that you might expect. You know, growing up in a family with parental fighting, divorce, insecurities, abandonment issues that might come from that, substance abusing parents, narcissistic parents that just aren't available in any kind of a nurturing or emotionally positive way, sibling rivalry, certainly childhood illness, parental illness, and then problems in school. Again, things that you might expect. Bullying, isolation, low self-esteem, patients struggling with their gender identity, patients struggling with the so-called body dysmorphias, too fat, too skinny, tall, short, acne, could be racial issues, religious bigotry. I mean, the number of things that can cause childhood stress, fear, insecurity, low self-esteem are as many as you can possibly imagine. Yeah, we're talking for the most part about post-traumatic stress from childhood stress or trauma, but the symptoms vary tremendously from patient to patient. What we see most often are depressions that have never responded to antidepressant medications, maybe anxiety disorders that have gone on to panic attacks, obsessive compulsive disorders, sometimes ritualistic behaviors, but more commonly, patients get into these ruminating, negative, self-deprecating thought loops. And those are the ones that start spiraling toward thoughts of self-harm or suicide. For other patients, it can become alcoholism or other substance abuse, just trying to self-medicate the pain and get through the day and the night. For women more than men, we start to get into some of the eating disorders, the bulimias and the anorexias. For other patients, it may turn into just frank rage and anger. So the symptoms vary tremendously from patient to patient, but always somewhat a function of the nature of that underlying childhood stress or trauma.
Now, just out of curiosity, because we see it a lot as far as patients using and prescribers that are pain specialists, and they're using it for pain. We know that it hits the glutamate receptor, the NMDA receptor. Now, do you ever treat patients for pain or no?
Yeah, we do. You know, we have 8 treatment rooms, and 2 of them are reserved for central neuropathic pain. So there's pain and there's pain. Okay, the kind of pain that ketamine treats is what we call central neuropathic pain. The easiest example I can give of that is something like a phantom limb pain. Somebody has a leg amputation, and yet their brain still thinks their foot's in excruciating pain. So they're dealing with excruciating foot pain when there is no foot. It's brain misinterpreting information coming from the stump. So that's the kind of pain that ketamine addresses because it's actually treating the root cause of it. It's blocking sensation from getting to the stump to the brain, and during that 4-hour infusion, it allows your brain to reboot. Now, that mechanism of action is very different than when we're treating mood disorders. When we're treating mood disorders, we're actually stimulating new dendritic and synaptic growth and restoring connectivity between the neurons in our mood centers. So the mechanism of action is different, as is the treatment protocol. For example, patients coming in for mood disorders, like a depression or an anxiety, might be here for an hour and a quarter, and they walk out the door and go back to work. Our pain patients are here all day long. They get doses that are 10, 15, 20 times what our mood disorder patients get. with a lot of sedation, and they essentially sleep through a 4-hour infusion, and then there's a slow 4-hour recovery. So very different protocol, very different mechanism of action.
So that leads me to my next question. As far as the protocol goes for the patient experience when they're getting the infusion, and I had the experience and the privilege of sitting in on a patient that was getting a ketamine infusion, and to see what they go through, and they have to have the blood pressure monitor and so on and so forth. So what is the process? And I don't want you to give your secrets up as far as giving an infusion and having a patient sit down for 4 hours and have a ketamine infusion.
Well, when we're treating central neuropathic pain, they essentially sleep through it, okay? There's a lot of sedative medication in addition to the ketamine. So it's kind of a 4-hour nap. And then it takes about 4 hours to get all that medication back out of your system to the point where they're actually ready to safely leave. And we don't let them just get into an Uber. They have to be picked up by somebody known to them.
Wow. Okay. Now, as far as dissociation, do most of them dissociate, or you only see some patients dissociating?
Some may not. That's not the goal of treatment. You know, there's a lot of confusion. The more you read about this stuff in the literature, it's very confusing. Some people will lead you to believe that unless you have some wild dissociative experience, you're not going to get any benefit. In fact, you don't need any dissociative experience to respond to ketamine. So that's not what we strive for. Some people may wander into some mild dissociation, but you know, they may feel like their arms and legs are a little heavy, maybe a numbness tingling around their lips, maybe a little bit of a floaty sort of out-of-body experience, but it's very well tolerated. We encourage patients to listen to fun music, rock, pop, hip hop, things like that.
So do you play the music, or do they play the music?
No, they bring their own, or they can watch a podcast, and many come with a friend or a relative, and they just, you know, chat for the hour they're sitting there. Okay. So yeah, the having a dissociative experience is not required. And, you know, it's something that a lot of people worry about. You know, they worry about losing control, and they may be having flashbacks of some really traumatic childhood, you know, events. And so it's nothing that we, you know, try to achieve at all. It's not the goal. The goal is just delivering the ketamine. The ketamine that you get while you're sitting in the chair doesn't even translate into new dendritic and synaptic spike formation, which is what we're here for. We're growing dendrites and synapses. But that process takes 8 to 10 hours. And so none of that's even happening while you're here. There's a total disconnect between what goes on later on and what you're experiencing during the infusion.
Oh, wow. So that process takes 8 hours. I thought, to be completely honest, I thought that happened right away. So that's an 8-hour process. So the patient at home.
The earliest that anybody begins to feel better is the next day. But Chris, even that's only 20% of patients. Most patients really need 3 or 4 infusions before they begin to notice something. So again, there's a lot of misinformation out there. And you know, the numbers and things that I come up with are based on, sure, like I said, you know, or like you said, we're in our 9th year now. We've treated actually not 2,400 patients. We're up to 4,500 patients.
Wow.
So we have the largest single office experience in the world. So, you know, we pretty much understand the best way to approach these patients.
Okay, so that kind of follows through to the next question I had in mind. As far as the protocol, is it usually that 6-week time? Do they come in 1 week? Do they come in twice a week? How many infusions are they getting within?
Okay, so initially we start with 6 infusions on an every other day basis. So for most patients, you're talking about initially 2 weeks or so. Okay, it's actually 12 days. And since we're here 7 days a week, patients can come in on weekends as well. So we're almost always here, excuse me. But following that initial series, if they are in the group that has responded and they are feeling significantly, if not dramatically better, we generally find that not only do they feel and function better, it's perhaps the best they've ever felt in their lives. And that goes on for maybe a month and a half. And then over a couple of days, your mood may start to slip a little bit, and that's what's expected. At that point, they come in for a booster infusion, and they're good for, say, another month and a half. And we don't schedule these, Chris, because the interval varies tremendously from patient to patient. So we just tell the patients, call us when you need us. I don't want you spending time or money on something that you really don't need. And that coming in every 4, 5, 6 weeks isn't for the rest of their lives. But what we have found over many years, though, is that for about a year, patients do come in on a somewhat regular basis. And then after the first year, the need to come in starts to drop off pretty quickly. And we find the interval between visits just starts getting longer and longer. And then eventually we just never see them again. I mean, there are a few patients, a certain percentage of patients that will continue to drop in from time to time over several years. But for most patients, though, it's not a long-term process at all.
Wow. So this is not cookie cutter therapy. It's pretty much tailored to how.
Everything we do is so individual, from the doses, speeds of infusion, frequency. Yeah, there's no recipe. There's no cookbook for anything that goes on in this office. The only thing that's somewhat consistent is for that first dose, we start at about 0.5 milligram per kilogram of body weight.
Okay.
But where it goes after that is really a function of how the patients are doing and, their comfort level. And so it's quite individual. And so each time a patient comes in, there's a discussion. How are you doing? How are you feeling? How was the last infusion? Are you starting to feel better? Once patients start responding and beginning to feel better, we generally level off the dose. There's no reason to keep pushing the dose at all. Because with higher doses, you run the risk of getting into some dissociative experience, which, patient A may think is fun and interesting. Patient B may find it very, very frightening. Yeah. So we'd rather avoid it.
Okay. Now, as far as the troche, where does the troche come into play? Which, for those of people that don't know, a troche is a buccal lozenger that goes into the inner cheek. Yeah, so sometimes ketamine can be used for in a troche form. So where does that come into play, Doc?
Yeah, we prefer to call them lozenges because people can relate to that.
There you go.
They know what a lozenge is. Okay, troche. I'd like to know where the pharmaceutical world ever came up with that word.
I don't know, but everyone says it differently too. No one knows how to say it right. I don't know how to say it right, I guess.
Yeah, some people call them troches, troches, whatever. But the first time you mention that word, people are scratching their heads. What the hell is that? Yeah. Hope it's not a suppository. So we use the lozenges or troches on 2 different kinds of patients. Our central neuropathic pain patients that do respond to ketamine, quite often we'll just continue them on those twice a day. They're able to function quite well. They can work, they can take care of kids, they can drive, they can pretty much do anything they'd like. The doses are quite small, the absorption's quite low, but it gives them that constant kind of ketamine hitting those NMDA receptors in the cord, and really can be quite effective in ameliorating their pain and in maintaining the good work that we got out of the heavier dose infusion. We're talking about our mood disorder patients, the depressions and anxieties and stuff. Not every patient gets those. Now, patients that can go 4, 5, 6 weeks between booster infusions generally don't need them at all. But occasionally we get patients that, maybe they feel they need to come back after 10 days or 2 weeks. And it's just okay, it's safe, but it's inconvenient and it's expensive to come back that often. And, we worry about everybody's wallet. So for those patients, we prefer, if they agree to just go on the daily ketamine troche supplement, where every day they're getting a little bit of ketamine too. It's working a little differently. And they're not substitutes for the infusions. In other words, you can't just start with troches and stay on them. No, what they are really, though, is extenders, okay? So once a patient's had the intravenous ketamine infusion experience and have attained a certain level of improvement, we can use these lozenges then to just extend the duration between infusions. They still keep coming back for infusions, but instead of needing to come back every 10 to 15 days or so, we get them back out to that 4 to 6 weeks. And that's a real benefit for those patients.
Okay, fantastic. Now, you got involved in ketamine a long time ago. So you've been doing this for a very long time. And the progress throughout the years has been extensive, and to see how popular it's become, it's in the news, it's here, it's there. Where do you see, and there's an FDA approved form of ketamine that's synthetic S-ketamine, enantiomer. Where do you see ketamine in 3 years, 10 years? Where do you see it in the future?
I think it's going to continue to have an extremely important role in managing the treatment of otherwise treatment-resistant patients. I don't know that you're going to see any change in ketamine per se. I don't know that you're going to see dramatic changes in protocols in the way it's administered. Other medications may come along. But when I look back over the last 9 years or so, we're not doing things much differently than we were at the beginning. And, I think we've kind of perfected what we do in terms of maximizing our outcomes. So I'm not quite sure where ketamine is going to be in 3 and 10 years. I think it'll certainly still be here, and I think it'll still be important. I don't think anybody's going to be making any important changes in the molecule itself. So I don't know that I've answered your question, but I still expect it to be quite important going forward.
Yeah, no.
There's a lot of discussion about introducing the so-called psychedelics, the ecstasies and psilocybins and things, and whether that.
Yeah, what are your thoughts on that? Did you look into that as far as what the future holds? Because you hear that a lot. I know there's a couple of companies looking into it and researching.
It's still in its infancy, and there's not a lot of information. There really isn't. For example, even though we know very precisely how ketamine works and why it works, I don't know that anybody has done the basic science research to kind of figure out how these psychedelics work. And for me, I'd have to understand what they're really doing. The psychiatric world, I'm talking about the world of psychiatrists, the American Society American Psychiatric Society still hasn't really embraced the psychedelics. There's very, very little in their literature about it. And until they show a little bit more enthusiasm, it's difficult for me to become enthusiastic. And Chris, there are a lot of hurdles too. I can't imagine how long it's going to take to get FDA approval. There are a lot of legal battles. I think there'll be battles in each state. And it's going through the procedure with either of those psychedelic meds, again, the psilocybin or ecstasy, is extremely time consuming. And I think it's going to be extremely expensive. So I'm not quite sure if it's ever going to be available for the masses the way ketamine can be.
Yeah, no, well, we'll see in the future. Only the future is now, I guess.
They may turn out to be quite successful and important. I think it's just too early to know.
Yeah, well, hopefully we see something in the future. And listen, I really, really respect what you've done, what you're doing for your patients. We're dealing with patients that are in serious, serious conditions, and what you do is you go beyond, above and beyond for your patients. So I appreciate that, and I believe everyone out there in New York, around the world,
Thank you, Chris.
appreciates that. So, as far as the viewers and listeners at home, this is the New York Ketamine Infusion Center. And can you just give your phone number of the New York City, because you're in Melville, New York City, New York
Well, we're
City.
in both. We're in both. Our main office is actually downtown Manhattan, 75 Maiden Lane. It's just a couple blocks north of Wall Street. So we're pretty far down. And that office is open 7 days a week. And the number there is 917-261-7370. We do have a new satellite office out on Long Island now, in Melville, right on the Nassau-Suffolk border. That office is only open 3 days a week, Monday, Wednesdays, and Fridays. I'm there every Wednesday seeing new patients. But the other 6 days of the week, I'm here in the Manhattan office. But it's the same phone number in terms of scheduling. It's 917-261-7370. And if a patient calls for information, we start with an initial, well, I guess you could call it a screening process. Either Dr. Knightlick or myself will call the patient and have a phone conversation to see if in fact it's likely ketamine might help that particular patient. Again, we don't want patients spending time and money on something that's unlikely to help. So we're looking for certain profiles. And then after that, if we think it's likely ketamine can help, then patients come into the office, and then I sit down for their first visit, first infusion. But before that first infusion, I sit down with them for another full hour. We spend another half an hour going over their mental health history or pain history. And then I spend an additional half hour just talking about ketamine, how it works, why it works, history of the drug, going over our protocols and getting them comfortable with the whole process. So that's pretty much it if somebody does contact us.
All right, fantastic. Well, that's Dr. Glen Brooks. Thank you so much for coming on. I appreciate it.
Well, Chris, thank you so much for inviting us.
All right. You have a good one.
And thank you for all your good work. You've been amazing and very responsive to all our patient needs.
I appreciate that. It means so much, Doc. Thank
All
you.
right, sir. Take care.
Be sure to search Precision Opinions Live on Stitcher, Spotify, YouTube, and Google Pods. And make sure to follow Precision Pharmacy on Instagram, Facebook, and all other social media platforms.